Hi, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm joined by my co-host, Dr. Johanna Richey. Hi, Joe.
Hi, Jeff.
How are you doing today?
I'm doing great. It's fun to be in the studio.
Oh, I see that. You got the headphones and the fancy mic.
All
right
tuned
on.
in.
Well, we have a phenomenal guest today, Joe. Dr. Tim Dutra from California. He's an alum of the California College of Podiatric Medicine, same as me. And I love your PodSquad shirt. Welcome to Dean's Chat, Tim.
Thank you. Pleasure to be here.
You know, we're super informal on Dean's Chat, so if it's okay with you, it'll be Tim and Joe and Jeff.
Well, you don't call me Timothy.
Then you're in trouble.
Yeah, my mom and dad. Oh, that was bad. Yeah.
So, Joe, do you want to give Dr.
Absolutely.
Dutra,
So
Tim,
I'm thrilled to have you here today, Tim. Thank you so much for taking your time to come and talk to our audience with all your expertise and insights that you have. I've had the privilege of working with you for, 10 years, almost 11 years. And for a small portion of that was actually in person together, which was really lovely. And I loved having little chances to pop by and just get your take on so many different things. But to give your formal introduction, Dr. Tim Dutra graduated from University of California, Davis with his bachelor's degree in psychobiology, which I'd love to get some more information on that. Went on to do a master's degree in science of kinesiology, as well as healthcare administration many years later, which again, another fun fact I didn't know about you, from Cal State Hayward. Went on to do your residency fellowship with Dr. Doug Richey, who we will have as a guest coming up soon in Pacific Hospital at Long Beach, California. Some of the really fun things that I would love to highlight about you, Tim, is all your experience with sports medicine. You've been an active member of the American Academy of Podiatric Sports Medicine. You've won the Distinguished Service Award from Dr. Robert Barnes in that professional community. You've also been the team physician for Cal Berkeley Athletics, as well as Cal State East Bay and the Golden State Warriors. So welcome to Dean's Chat.
Pleasure to be here. Thank you for inviting me. It's an honor.
Yeah. So I would love to hear, how did you find out about podiatry? How did you get into this? And tell us your experience and your journey.
Wow. Okay. That's a loaded question. From a real young age, I was always very interested in medicine and also sports. So that's hence the sports medicine interest has always been the root of a lot of my motivation and passion. So just a little bit going way back, during my childhood, I actually came down with polio. So I had a mild to moderate case of polio. And one of the main things that came out, I missed quite a bit of a year of elementary school, but they really said you need to take up sports, play all the time, do everything. So that kind of was my main, I guess, thrust into the sports arena as a second and third grader. And I always have loved sports and staying active. So that also, with the kind of care I got, I was really impressed with healthcare and with medicine. And so I thought, wow, this is interesting. So, I did sports my whole life. I was one of those, what's it called, jack of all trades. Back then we basically would play 3 or 4 sports a year in school. That was kind of my normal upbringing. So I loved sports. When I got into college at Davis, I went the psychobiology route because I was basically a pre-med. I liked physiological psychology and some of the other things with that. Played on the tennis team there, got into the athletic training program. So then I went to graduate school, Cal State Hayward at the time. They had a kinesiology program with sports med emphasis, became the graduate athletic trainer up there, got to be the head trainer at De La Salle in high school in Concord, which is now a powerhouse, and it wasn't because of me, but I wish it was.
You helped.
And so I loved athletic training because that was really a hands-on, multi-sport, we covered all the sports. But I found I could relate because as an athlete, I'd had a lot of injuries and I really appreciated what they had to go through and the psychology behind getting them back to the level they wanted to be at. And also, I loved kinesiology and gait analysis and motion. So everything kind of blended together. And really what it came down to, I was, running for conditioning, especially during my tennis years, and I got plantar fasciitis. And of course, that led one thing to another. And I had seen a lot of that in our athletes in high school and college, and went through that treatment. I go, wow, the majority of the injuries we see are foot and ankle related and related to lower extremity. I said, wow, this is for me. And I love the different sports, and I love the student athlete part of it too, because students are great to work with. So again, we can kind of discriminate between professional sports and college sports and youth sports, but they're all fun. So anyway, I enjoyed that. And then at the time, my girlfriend, who's now my wife, her roommate was a podiatry student she grew up with her down in Southern Cal. And so when I was doing my kinesiology homework, she was doing her podiatry homework, we'd be talking, and go, wow, this is a lot of what we're doing. So anyway, I only applied to CCPM, and I got in, and I'm really glad I did. I thought it was a great training and educational opportunity. We had what I call the pod fathers of biomechanics there, just tremendous. And many of them also had the sports medicine emphasis with that. So it was just a perfect fit. I loved it. Went on to do my residency down in Long Beach and worked with Doug Richey, and we would work the marathon, different events, all that. I loved it. And then I did my fellowship through American Academy of Podiatric Sports Medicine in Long Beach. And that was at John Pagliano, who had been at the Olympic trials, I believe, for Mexico City, marathoner, but had a great practice. So we just basically ate and breathed podiatric sports medicine, and then so that's kind of a rough way in. The American Academy of Podiatric Sports Medicine is really has been a great organization for me, and I kind of grew up in it. So I developed a student chapter at the schools about 40 years ago as a student, because I really thought this was a great organization. Went through the fellow and training program with Dr. Pagliano. At the time, there were only one or two approved programs, I believe, in the United States. So I said, wow, this is great. And then basically went on to become president of the academy, fellow president, and then just developed, and now I'm a mentor and I keep involved with it. So it's kind of a lifelong thing. And then another sidelight on that is Special Olympics. So the academy was very important in developing the healthy athletes fit feet part of the program. Dave Jenkins, of course, huge with that. Pat Noonan, got Rich Boucher, a bunch of them. So anyway, it just kind of has been a fun process, because I'm very passionate and enjoy sports at all levels, all types. So that's how I got into podiatry. So it's a great, and when I go to the pre-med panels, so when we're encouraging different careers, it's amazing how many of the interested students are interested in sports medicine because of their athletic background and or their family members who have been involved. So it's been a wonderful, I think, mesh for podiatry. And I will tell you, because we're all well-rounded podiatrists, sports medicine isn't all we do, but I carry that philosophy into how I treat all my patients. I treat them all as an athlete. We all want the return to activity level. Everything's similar. So anyway, the philosophy goes with it. So there you go. That's how I got into it.
I have to just say, this is also my favorite thing about you, Tim, is the fun factor. Like, if you go somewhere and Tim's there, it's going to be fun. I don't care what it is. The fact that you just credited your mentors as the pod fathers, we're going to have to do something creative and clever with that, because that is just fantastic. So thank you so much for sharing.
You bet.
Throw it to you, Jeff.
Let's dive into the Podfathers. I've always said that if there's a hall of fame for biomechanics and sports medicine, it needs to be in the San Francisco Bay Area and centered around CCPM. Can you talk about some of your mentors? It's almost a trip down memory lane for me.
Oh, sure. So when I was in my graduate program in Hayward, which is the East Bay, we had a real up-and-coming star there. Steve Subotnick was one of the big ones. We had Harry Lavac. So we had some of the early ones, Tom Scarlato. We had a lot of big names that were just developing. Bob Barnes, who would come up to the school. Rich Blake, Bill Olson. So we had a lot of the younger guys, but getting back credit the Podfathers. So we had Root, Weed, and Orion, who were, wrote the books basically, and were really our early educators. And fascinating. We had a great individual, Ron Valmassi, who was just fantastic. He had a good sports med flair as well as podopeds. So gosh, Rich Bogdan, Chris Smith, I can go on and on. And I feel like it was such an honor and a privilege to have all of these giants. And they were very approachable and trying to make it clinically applicable to what we're learning and not making it kind of a math equation, So we were very fortunate. Plus, our clinics at the time were huge. We would see all the professional teams would come right through our clinics. We had the Niners, the Warriors, all the college people coming through. And the good thing is they didn't just come obviously for sports medicine. We had the surgery set up. We had everything else there. So I think having that influence was great. And I'm going to share one real important thought that really goes through all of our educational process is I was always taught biomechanics is the foundation of podiatry. So if you compare it with dance, ballet is the foundation of dance is kind of how I would use an analogy. And, I think we're so fortunate to have that because to become a good surgeon, you have to know your biomechanics. What are we doing to the foot? How is it going to change? How do we know this is the best procedure for everything else involved? So there's so much involved, and that's one of the things that really interested me in biomechanics and sports med was we were kind of like crime scene investigators, right? You're kind of taking all this material and you're trying to figure out, okay, what's going on here? There's challenges when you're treating athletes because you can have a simple diagnosis like plantar fasciitis, but if they're a gymnast, crew, swimming, some other sport, you're going to have to kind of adapt your return to activity guidelines, your rehab guidelines, and I think that makes it fun, much like surgery. I think a lot of the principles we learn in sports medicine, when you do surgeries, you want to make sure you're doing the appropriate rehabilitation, giving them strong balance, all that. So anyway, but I think we were fortunate during that era. The 70s and 80s were kind of the big growth of biomechanics, and we were fortunate to have that local. So again, I just feel very fortunate. And then even when I went to my fellowship, residency and fellowship, we had John Pagliano and Doug Richey, who were also trained in that. So I think that all helped. So, and I tell you, I owe so much gratitude to all of them. And I'm big on recognizing mentors because I think we all have great mentors, and it's important to let them know, I think, how important they were to your everyday practice. So again, just privileged and honored to have had them. And that was real brief. We could go on and do all kinds of bios on them, but I think it's really interesting. And Paul Scheer, I didn't mention Paul Scheer. I know I'm forgetting people. There's so many names out there. We had the MO lab with Nadi Bumpo and, all that. So anyway, it was fun. And then we had the up and coming stars, Kevin Kirby and Rich Blake, who were just starting out. They had done the biomechanics fellowship and just great individuals. So it was nice to see that torch carried. And that's one of the things that as an educator, we always want to make sure the students are aware of a little bit of our history, at least, and where we're going. So.
Yeah, I think back, and I didn't realize it at the time how privileged I was to have Dr. John Weed teaching our first biomechanics course.
Right.
And it was over our head a little bit, as you can imagine or remember. But wow, what an opportunity and what an incredible experience. Yeah, we can go on and on about more of that too. So Joe, the floor is yours.
Yeah, so I'm so curious, it's hard sometimes as a student, right, to recognize what you have in front of you while you have it. So once you started to kind of realize how special that was to, for lack of a better term, grow up in the Podfather era, what were some of the most interesting things happening at that time in terms of trailblazing for biomechanics?
Oh, yeah. Oh, great question. So one of the things when I was coming along as a student and both in college and then graduate school and then in podiatry school, the running boom was really taking off. And the running boom really put us on the map. and I was a cross country runner, but I ran more for conditioning and fun. I wasn't a real diehard runner like Subotnick and Pagliano and Richey. They were all big time at Kirby, big time runners. But I think the running boom that was my in. And then, like I say, I enjoyed playing a lot of other sports. And so what happened in the mid 80s to late 80s is I think podiatry really started branching out and becoming known more for just treating runners. And that's one of the things I like and encourage our members to get involved with sports, colleges and professional teams and all that, because we can offer so much to a variety of athletes. And I don't want to leave out dance, like the dancers, the dance studios. I mean, there's so many areas. And I think that's the biggest thing I saw, the biggest boom. And I enjoyed it because that really fit well with me since I liked different sports and had participated in a lot of them. And I've also coached a lot of youth sports for years. So I've always appreciated, soccer, baseball, basketball, tennis, all those. And there's so much we can offer for that. And then we get into footwear. So the footwear thing really changed. Orthotics, the whole process of orthotics, the customized orthotics, the materials, the top covers, how they interact with the shoe gear and any braces you're wearing. So again, I just thought it was a big boom. And I read pretty much anything and everything that I could on it. The other organization I was going to say, American College of Sports Medicine, is another big one. That's an interprofessional one that I've been very involved with for years. And it's been great because you get a lot of interaction with the kinesiologists, the biomechanists, the orthopedists, all of the coaches, the trainers, all that. So I think that's a big part of the real world interprofessionalism. We carry a lot of the sports terms. When you're an athlete, being a teammate, I loved being a teammate. I loved working with a team for a common goal. We have a lot of, I think, similar analogies in our profession. We're all working for a patient, so that's a common goal. We want teamwork. We want all this and that. We want to get them back. So I think a lot of the things we learn, and there's ups and downs as an athlete, right? You're not always winning, are you? And it's not all about winning, right? So you have all these philosophies and things, and I think we came in at the right time. I think having our biomechanics faculty just taking off at the school and incorporating, I think sports medicine has really helped biomechanics, I think, tremendously. And they are part of each other, obviously. But so I think that's the biggest change I saw. And also the athletic training emphasis, having been an athletic trainer and seen that the athletic trainers are probably the biggest friend because they're the ones with the athletes all the time. They're the ones who can tell us, are they wearing their orthotics? Are they doing their rehab? Are they wearing the corrective shoes? No, they're out in their flip-flops walking on campus all day long, and they're wondering why, their injury's not improving as much. So anyway, they're a big part of it. I think having that background is important too, that we appreciate, the coaches, the athletic trainers, the equipment managers, the whole group. So I think it's all important.
Tim, can you comment on the evolution of orthotics over the years? Because I remember working in the biomechanics lab and on weekends making Roador orthotics and not wearing a mask. I know I've got residual lung damage, I'm sure. But it's really changed over the years in terms not just of treating patients, but for preventing injuries. So do you mind commenting on orthotics?
Sure. So let's just make a couple rough comments because there's a lot of materials out there. A lot of our older podiatrists, and what I mean by that, pre my era, coming in, use a lot of leather. They call them leather inlays, and they use different types of materials. But I think that all helped. In other words, where we've really had the biggest, I think, impact has been getting to a more durable material, being able to coordinate how much flexibility, shock absorption, all that. So obviously, Roeder was a big material back when we were in school, and I believe they found that there was a correlation of cancer with all that. We can go into that too, but it wasn't a great material to be working in because we didn't have, some of the hoods and venting system and things we were doing probably weren't the greatest. I mean, I used to come out covered in dust, but but I think going to the polypropylene or the plastics, very durable, very moldable. Then we started getting into the graphites, and I remember, Chris Smith and Northwest Lab was starting going to the graphite and the ultra thin graphite. They even had fiberglass prior to that. So they're looking for lighter, lower profile type of devices. But then you also have the one issue with athletes is most of them, and if you're looking at collegiate athletes, the average athlete isn't 140 pounds, 5'6". These are big, heavy athletes, a lot of muscle. And so we're looking for durability. And of course, as podiatrists, what's our goal? Control that biomechanics. But the athlete wants comfort. I want something nice and soft and flexible, right? And so we're always caught in that middle. And then what the heck kind of shoe are you wearing? What are you wearing? One of these real flexible types of shoes when you have a hypermobile foot and blah, blah, blah. So we're looking at all of the different materials. Top cover materials too has been a big evolution because we get a lot of athletes who are playing on wet fields. And they need top covers that are more water resistant, and the wear and tear. How many athletes come in and go, "Doc, my orthotic's broken. I need a new one." And you go, "No, you just need it recovered." The actual shell's good, but everything else is falling apart. So getting back to your original question, I think the evolution of a lot of materials has been great. I think it's going to be interesting with the 3D printers and the other things coming out with what kind of materials, how it's affected by the way it's captured, the way the image is captured. So I think that's going to be a really interesting case. We can get into casting versus scanning, and the weight bearing and the biofoam. There's so many different ways of doing it, and I don't want to be critical of any of those methods. I think the whole thing is we have to appreciate and understand the pros and cons of each of the methods and the actual athlete. The other thing is getting back to what's the purpose of the orthotic? Is it a panacea cure-all? No, it isn't. It's used to help recover from injuries and also not necessarily prevent, but reduce likelihood of injuries. I think it's really, you got to be real careful about our whole concept, and I share this with the students, the whole concept of over-promising and under-delivering, do the other. Make sure that you're working with that. And so one of the biggest challenges I think we have in sports medicine is controlling the athlete appropriately in a comfortable device they're going to use, and then selling them that the coupling idea, that it's with the shoe and the sock and everything else they're wearing. You can have a great orthotic and you put in a crappy shoe, what's going to happen? So, we have our sayings, the orthotic's only as good as the shoe you put it in, and it has some truth to it. So anyway, there's that whole method. But yeah, the evolution, I think we have not stopped with that. I'm sure there's going to be new materials. I think the whole concept, though, is making it more durable, keeping it low profile. I think that's the biggest thing.
Joe, can I ask one more question?
Yeah.
So Tim, I have always been plaster, right? I would do plaster cast, neutral positions, tailor joint neutral, both axes of the mid-tarsal, maximally pronate. I see these scanners and I see pictures online, and foot's plantar flexed, the toes are dorsiflexed, and they're scanning from all these weird angles. How can they possibly capture a foot if the foot's not positioned appropriately?
Okay, great question. So, obviously, we were taught the old gold standard, of the neutral position casting technique, and for a reason, because we wanted to replicate it. So we had the 10 checkpoints of a good negative cast. I don't want to bore you with that, but it's very specific to make sure you're capturing what the foot looks like in neutral versus what your cast is coming out with. Now, one of the issues with scanning, it's very interesting you're mentioning this because we're doing a study right now funded by Chris Smith, which is great, in our motion lab. And we are using a foot positioner that actually holds the foot. We set it up, it'll hold it neutral. So you get rid of that problem, and then it's scanned. And I have to tell you, it's worked really well. And of course, I'm skeptical until I actually try it and see it and compare it. It's very hard to do comparison studies between scans and casts. Very hard, because you always have that objective data. So we can do pressure, plates, sensitive things like that, in shoe technology to check that. But there's all of the subjective part. Do you feel better in them? How's your balance? Are you more functional? So anyway, it's very complicated. But I think to answer your question, the whole concept of custom orthotics in the podiatric profession has always been, we do it much different than anyone else that does, any of the other providers, chiropractors, physical therapists, general doctors, whoever. We're big on the subtalar joint position, casting out the supinatus, or even scanning it out, right? So that's the one thing that the foot position allows you to do. And I think the problem was when the scanners were coming out, I think they were really made for more the non-podiatrists at first, just a way to really scan and do stuff. That's just my opinion locally. I saw it with the other types of practitioners, but I think these studies are going to be really important. So we're actually doing a study that's going to compare, we're controlling the shoe and the sock and everything else, and we're going to get the foot posture index. So we're going to look at high arches, low arches, all that. We're going to look at, do they have a leg length difference? Do they have supinatus? Do they have these? But is the orthotic doing what it's supposed to do? Is it actually showing the pressure shifting into a more optimal, I guess, for lack of a better term? But I think one of the most exciting things as I'm going through the end of my podiatric career, nearing the end, is seeing that there's so much evidence-based studies we still need to do objectively. And it's very hard because the more research I've done, the harder it is, because you start looking at all the control things. Like, we better make sure we control the shoe we're putting in. We better make sure we define the type of orthotic and the amount of flex that it's in. There's so many components, the referred posting, and then looking at the different foot types, because, again, to oversimplify, a cavus foot that's more rigid will not have much motion available. Obviously, the pes planus is going to have a hypermobile type thing. So obviously, you'd think the hypermobile foot you want to control more, right? So we have to look at all that, and then also a rectus foot. How does a rectus foot respond to that? And then the ages, the gender, the weight. I mean, there's all this stuff. So yeah. So I think with casting, I think with the scanning, and then I think for the 3D printing. The other thing about the 3D printing that's kind of, I don't want to say annoying, but I'm very impatient with, is a 3D printer. Ideally, you'd want in your office, right? So you can just go ahead and do it. But right now, a lot of the labs say, well, we can do the 3D printer for you and all that. But then I'm going, like, to me, that kind of takes some of the reason I would use 3D printer kind of out of the equation, because I would use it for convenience and being right there. Well, if I have to send it out anyway, image or scan or whatever you're doing. So anyway, but I think it's changing tremendously. And I think that's what's exciting. I tell the younger students and even the pre-meds, that's what's exciting about podiatry, is we've evolved, we continue to evolve. And I think all of us in the educational areas to appreciate that we can keep expanding this. And our job for the students is to prepare them to be well-rounded and ready to go, and be aware of the different things coming up, the technologies, and what are they most comfortable with. So we like all of our students to be comfortable doing, all those techniques, because when they go on their private office clerkships, they do their core rotations, they'll feel more comfortable. So anyway, I know that's a long answer.
It doesn't surprise me that Chris Smith is leading the drive to standardize it. If you see him, say hi for me. I haven't seen him.
Will do.
And I think it's great too that you guys are championing a lot of this, because I think we're like on the cusp of another kind of explosion in technology, AI being able to be used in this capacity. But unfortunately, as we are learning, right, you have to have good models, you have to have good data, you have to set these things up in a standardized fashion. And so knowing what variables to predict for, knowing what questions to ask, is going to be a huge part of that, allowing the technology to take off. And we don't have a lot of those answers yet. So I think it's awesome that you guys are you've always been championing a lot of that biomechanical research, and that this is continuing to happen. On that, real quick,
Joe,
yeah.
And Joe, I think just a quick follow-up. I think it's really exciting that our students can participate in these projects, because part of our goal when we graduate a podiatric medical student is to make sure that they understand good research, good protocols, the difference in randomized trials versus a case study versus this and that. But it's really nice, and with biomechanics, it applies to everybody going out practice. They're going to appreciate what orthotics are for, how they can change plantar pressure, what are we trying to do with them. And I think if you just prescribe something, it's just like medicine. I tell them this: if they're prescribing a pain medication, you don't just prescribe it. You have to tell the patient what it is, how much you take, why you're taking it, blah, 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 all the precautions. And it's the exact same thing with orthotics. Like, what's the common goal? I keep it real simple. Even for my surgical patients, I only have 2 goals for all my patients: reduce pain and discomfort, increase function. That's all I'm doing. I'm not promising they're going to be pain-free and an Olympic athlete. I'm just trying to make sure those goals are common. And anyway, so the main thing I was going to say is that it's great to have the students involved in that process.
Yeah, absolutely. And I think what I would love for you to just comment briefly on for us is, as we target some of the students and prospective students, the Mark Lab that is at Samuel Merritt, can you talk a little bit about the technology that you use there and how you guys are making use of it in studies like this?
Sure. So our Motion Analysis Research Center is really kind of a dream project that I think we all had as students in the 80s and 90s. We all really wanted to get that developed. And so it's been, I think, 12, 14 years now we've had it there. But the main thing is we wanted it equipped right. So we went and visited, Brooks Lab, New Balance Lab, different biomechanics labs, and kind of asked them what are some of the essential things. We aren't product testing. We didn't want to do product testing, on shoes and stuff, but we wanted to do actual motion analysis. We didn't want it to be a gait lab or running lab. We wanted to be able to do all kinds of things. So, for instance, we can do aerial stuff. We can do all kinds of stuff there. So we have basically force plates in the ground. We have, I think it's a 10 camera system now going. We have a balance machine there. We have EMED. We have a PDOR system for in-shoe. So we have everything, and we can integrate it. And what's been really good is we've had people do, golf things, basketball things, like I said, aerial, almost like Circus Olay type of things. And it's also multidisciplinary. So it's really there to develop motion analysis and kind of share that with our different disciplines. So the hardest thing is, trying to get subjects and going through the IRB and doing all the studies right. And of course, carving time for that for our faculty to be able to do that. So of course, that's a challenge. But the Motion Lab it was under Samuel Merritt. Now it's under our College of Podiatric Medicine. So it's with us, which I think will really help us get more involved in, and I don't want to say control, but facilitate, I think, more types of studies and encourage our faculty. Now, from a recruitment tool, it's big because a lot of students go, wow, this is really cool. This is what I want to do. A lot of our applicants want to know what the podiatry colleges are doing for evidence-based studies. And I think I think there's so much we can all do for that. I think that's a big part of what we should be doing, because I think when you're doing research studies in an educational institution, hopefully we're getting a lot of the conflict of interest out of there, and we're really concentrating on what is happening, how is this going to apply to our profession, and how will this further our understanding in treating patients. As you know, without evidence-based studies, the insurance companies aren't going to reimburse certain things. So no matter if it's for wound care or surgical implants, hardware, whatever it is, we have to have that evidence-based study. So, but the Motion Lab, what I was going to say too, just in closing with that, is it should be a great tool for surgical biomechanics. We should be able to look at things like a Charcot foot, reconstruction. How is it going to really change? How can we better their outcome so we can use it maybe as a surgical planning tool, but also for the follow-up? What are you going to do postoperatively with this person? How are we going to keep monitoring and changing that? Because once you reconstruct the foot, it doesn't stop. It's going to continuously be evolving. So anyway, those are just thoughts, but I don't know if that was enough on the Motion Lab, but the Motion Lab, I think, has tremendous potential that we haven't really used enough, and hopefully that's starting to change. So I'm really excited. And getting our alumni to start funding some of these studies is tremendous because it shows that they're really looking at us as leading the charge for biomechanics and orthotic therapy, brace therapy, surgical techniques, all that. So I think that's exciting.
That's wonderful.
Absolutely.
Thank you.
You know what also I think is exciting, Tim, and would love for you to comment on it. Back in the 80s, we were so much emphasis on runners and athletes. And then we started looking at biomechanics of the insensate patient, your patient with diabetes. Yeah. I mean, what a different world that is, right? We've got two different areas: treating pain, treating patients without any potential to have pain. Can you comment on any research with? You're looking at patients that are insensate and gait analysis and pressure points and things like that.
That is a great question. And so when I first became full-time at the school, I was doing wound care trials at Highland Hospital. So we were doing all kinds of great types of wound care trials. The issue was, and as you know, our biggest challenge in diabetic foot ulcers is once we treat them and heal them, we got to keep them from coming back. And so hence the biomechanical analysis is very important with offloading. And there's only two ways to offload for our diabetic wounds: surgical or non-surgical. Oftentimes you need the combination. And that's a great point. The insensitive foot, we can see hot spots way ahead of time. And so many, in fact, as of course the whole audience is well aware, there's a huge amount of pre-diabetics, metabolic disease, whatever you want to call it, that are starting to get those insensitive changes and not even realizing it. And of course, they're at risk. It's very interesting with the wound studies we did is the majority of our patients were males. How come? Why do you think most of them were males?
History of noncompliance.
Yeah, females are more, on the whole, are more aware of what's going on, and they're going to take care of themselves. And I wanted to bring that up because that's also true when we're trying to follow up and offload them. Some of them had a hard time with doing that. And, we don't have to use the Frankenstein orthopedic type shoes now. New Balance, Brooks, a lot of the athletic shoe companies are making great extra depth, good shoes that we can put in insoles with. But the key, Jeff, I think is going to be trying to find out that combination between surgical reconstruction versus adequate support in a insole and a shoe, and maybe even a brace. And then how is that going to affect balance? Because remember, balance is very, very delicate, and it's influenced by so many things. And when you have an insensitive foot, wow, I mean, the proprioceptive part is huge. So anyway, those are, so I think what you're highlighting though, Jeff, is really important. Wound care, it's got tremendous potential. Sports medicine's got tremendous potential, and surgically. What more do we need? I think that's what's so exciting to all our practitioners as well as prospective students, because wow, look at what we can do. Not only are we surgeons, okay, but we're biomechanists, we're physicians, we're the whole shebang. You talk to any of our successful alumni out there, all of them say, make sure you're graduating well-rounded students. Make sure they understand all this. And so that's on all of us. And I think, again, I appreciate my mentors and role models because that's what they did. And, and I was fortunate, again, to work with Doug Richey. Doug was like that. I mean, Doug was great as far as biomechanics, surgically, and research-oriented. So it's hard to find that combination and the passion to do it all. Like, I love enthusiastic, passionate people, teachers, because they're going to relate to you. They're going to stimulate you to do that. So anyway, but yeah, that's a good point. Good point.
So, Tim, I'd like to talk about your PodSquad shirt there. Can you give us some origins about the PodSquad? That was early 80s, right?
Yeah, so the Pod Squad, I believe, started right around 80 to 81 in there, and the class of 82, which was Kevin Kirby's class, they had quite a bit of runners, and I don't want to leave anybody out, so there were a lot of good runners in that group. And so they were called the Motley Crew also, but they wanted to have kind of an athletic club. So the Pod Squad was dreamed up, and they came up with this logo. And on the back we Save Souls was one of them, and we Save Souls. I should remember the other. I can't read the back of my shirt. But anyway, we had sayings on there. But the good thing is we would wear them everywhere we went, and so people would identify Pod Squad. We had singlets, running singlets. We had sweatshirts. We had all kinds of things. These were reintroduced several years ago through the AAPMA with some of our former students. And so, and what we did is you would get one of these if you donated to student scholarships. And so it was a great thing to do. And, we need to do a little cleanup on this, change the name and the initials. But I love the term Pod Squad. Now, where did that term come from? Well, remember Mod Squad? Remember way back the TV show Mod Squad. So Pod Squad was a spinoff from that. So that's all. And I know Kevin would probably give you a lot more detailed explanation. But so our sports medicine club was called Pod Squad back then.
We tried to live up to the standards, the class of 91 that Kirby and his team put together. And we did the centipede at Beta Breakers with the CCPM banner. And we did it. It said podiatrists save souls. I'll never forget that.
I'll have to send you, I'll send you a picture of us in the centipede. From I think 1984. I have a picture of us, but it's pretty funny.
Oh, that's great. Oh, that's fabulous.
For those that don't know, can you tell what Beta Breakers is?
Oh, Beta Breakers, basically, you run from the bay to the breakers. So you go from, and I'm blanking, on Hayes Street at the beginning over there, near where the ferry terminal is. And then we go up over the hill, so up over Hayes Hill, then you come down into Golden Gate Park. And I believe it was around 7.5 miles. I should remember. It's been a long time. I used to run it all the time. But it's basically for serious runners, as well as it's like Halloween. I mean, it's a costume party.
Yeah.
And a lot of people would start walking it. I believe unofficially they had upwards of 160, 180,000 people there, even though officially it was much less. But I can remember our original centipedes at the time did really well because most of them were collegiate runners. And you know what crack the whip is? So like I always felt like I was being pulled, like, slow down, you guys are like, they're just, they were just whizzing through, but it was really fun. And at the time, the other interesting thing is we had women in our classes and women runners. So it was great. It was something we could all do, which was really kind of neat back then. And it really grew. My brother and I ran it when we were in high school back around 70, 72. Like 500 runners registered back then. And, it just grew. Another one is the Dipsy Trail. That one's a big one too. But anyway, yeah. So Beta Breakers is usually run, I believe, around Mother's Day. So it was just a couple weeks ago, and they had an outstanding group. What I'd like to see, though, is our school get back into, we had a mobile clinic, and Jeff, I don't know if you remember that, but we had the mobile clinic. And so we used to work at the end, at the finish line. It was so fun. So we'd run the race, hydrate, and power bar. And then we would see hundreds and hundreds of runners who had heel pain, blisters, twisted their ankle, all kinds of fun stuff, nail trauma, all that. So it was a good learning tool also. But the thing I liked, it was a great marketing tool for Beta Breakers. It really helped put us on the map, I think, for that. And then when we did the waterfront run, that was kind of the next big race that we did. One thing we do at our school is Napa Valley Marathon. So we try to do different stations. And what's nice is podiatry is really essential in that. And we actually get as much room just for podiatry as they do for all the rest of the medical people. So it's pretty cool.
Yeah, back when we did it, it was a Sunday, and we always had finals on Monday, so we didn't have that much time to hydrate appropriately, let's say.
Well, it's funny. The last one I ran was right before I was going down to Southern Cal for the fourth year LA County USC program. So I drove down that night. So yeah, so depending on when your finals and when your school year started, it was pretty fun. But it was a big part of the culture there. So it was nice being in San Francisco and being involved in that.
And another
Absolutely.
wonderful highlight for, as a student, part of
Oh yeah.
enjoyment, right? Like enjoy the experience. Like, yes, there's a ton of studying and there's a lot of time that's built into things that maybe is not as desirable, but you can build fun into the experience where you're learning and having fun at the same time. So I love that you highlighted that. Thank you.
So Tim, you're in the same situation we are. We're interviewing students and finishing off our class for the upcoming year. Well, what are you telling incoming students about podiatric medicine?
Well, as you can probably notice, I'm very passionate about. I love what I'm doing, and it's kind of one of those. It's not really a job, it's just a fun thing. And I tell them, I said, there's a lot of great careers in healthcare and medicine, a lot of them. And one of the things I did early on that I recommend they do is shadow and look into all the different things that make sense. So I was lucky in high school. I had something called the Medical Careers Club. And actually at Davis, we had a similar thing where you could shadow and even spend up to a month and get like credit for going to different types of things. And so I think one of the things is, first of all, telling them if you have an interest in medicine, and you must have the ability to pay for the education because there's a huge financial component, which I think is really getting out of hand. It's going crazy now. It has been, but I mean, it's a tremendous cost for them. And I think being able to sacrifice 4 more years, of going through a program. So basically make sure that your heart's in the right place, that you've shadowed that this is the career you want, and then go for it. And I think the other thing is you need to dream a little and go for these things. And I tell them, if you don't make it into the DPM program, there's probably a lot of other healthcare professions that you can still utilize a lot of your energy and talents for. And the nice thing about podiatry, so I tell them, the great thing about podiatry is there's not a lot of us. You'll be overwhelmed in most of your communities because everybody needs podiatric care. I think if you're well-rounded and trained to be well-rounded, you can really fit in pretty much any community well. Don't think you're going to just be doing trauma surgery or sports med or wounds. There's all that there. And I think one of the benefits of podiatry, we treat all age groups, cradle to grave, basically, all activity levels, and surgically, non-surgically. So it's just a tremendous growth potential professionally for all these students. And it combines a lot of things I like because I loved athletic training and physical therapy. So I love the rehab part, but I can still be involved in that as a podiatrist. I think also I tell them we're also role models for our patients, believe it or not. And so, if we preach exercise as medicine and it's really important to do this and that, well, by golly, we better be doing it ourselves too, and showing that we do that, or at least be involved in it, I think. And so I think getting that across to them is important. So when we're looking at recruitment, I think it's reaching all the bright minds out there that are pre-meds. Obviously, you want to hit them in high school too, but by the time they're coming in for interviews, you want to make sure that they know what podiatry is. They appreciate, I think, how it is different from DO and MD school. I think they have to appreciate that if you get into one of our podiatry schools, then you have that podiatric surgical residency, because if you get an MD and DO school, that's not guaranteed. You don't know, you might really want to be an orthopedic surgeon and you didn't get into that residency. So now what do you do? Well, again, I think there's a lot of the great specialty areas, but depending on what they want to do. So I always tell them that, follow your passion. If sports medicine, wound care, whatever got you into it, make sure you always emphasize that, though, and remember that, because it's sad to see someone who wants to go into something and then they totally don't do athletics anymore or dance or whatever they were doing. So anyway, so you need to look at that. You need to look at the support system, the financial part. But I think it's a great outlook because, again, we're always going to have patients who need us. Wound care and diabetes is, continuing to, skyrocket. So I think there's so much potential there. And I don't know if that answers your question, but it's a challenge for all the schools. And by the way, I have always thought that I think all our schools are great. And I tell them, find the fit, find what fit is there for you. Much like going to college, it's the same thing. You're going to find a good fit. But I think it's a great profession to go into. And, COVID pandemic did change things. But the good thing about biomechanics was we pretty much kept going and kept our access going. And I think that's one of the things of healthcare is you want to be a doer, you want a hands-on, and that's the advantage of it. We can follow our patients. So if you've done surgery on a patient, you don't lose them as a patient. Now you're treating them for other things. And so they're part of a family that you're kind of just, taking care of that whole time. And I think that's important. And then also respect the interprofessionalism that you need to work as a team. Podiatrists are not the sole answer for everything. We have to work with a lot of the other professions. And remember, it's for the patient. So we focus on the patient. Much like educators, we focus on the student. It's the same thing for the patient. As long as we have their best interest involved, I think we're going good. And we need to really get the good young minds coming out and applying to our schools. I think it's really important. And most of it's awareness. We do a lot of high school workshops now, and you'd be shocked at how many say, wow, I didn't even know what podiatry was, and this and that. They have misconceptions. They don't even know what we're doing. And so I think getting that out, our biggest obstacle is education for the community as well as the high schoolers and the bright science minds. And they do have to, I tell them, you have to be good in science. You have to start caring who you hang out with in high school. You have to start making sure that you're utilizing everything early on because it's really hard to be 22 years old and say, oh, I want to go into podiatry and oh, you missed a lot of the prereqs. You have to make up a lot of ground. I'm not saying you can't do it, but anyway, so I think that's the big thing is really reaching out, getting to them early, having them shadow, have them go to a variety of different practice types. And then, as you know, we have, much more women now as our students. And so I always tell our women's students and applicants, make sure that you also visit a women's office. If make sure you get a good variety and see what's out there, because I think there's so much potential now with what's out there for practice availability too.
Well said. Well said. I interviewed a young lady this morning, and she just found out about podiatry like a year ago, and she had never heard of it before. So what you just said, Tim, about awareness extends way beyond high schools and colleges. We need a branding opportunity for the entire United States so that the populace understands what we do for foot and ankle issues.
Jeff, that's really important. It's a grassroots effort. And I can say when I was in private practice, I mean, I probably do 10 to 12 pre-med panels a year, and I always have. And they're really well attended because we have all kinds of panelists there. And then when I got out to school, I kept feeling, getting this feel like they expect the school to do all the recruitment and everything. Oh, no, we have so many outstanding practitioners out there that can really spread the love and let them know. And we actually encourage a lot of high school shadowing, like get out there in high school and shadow. And it's amazing once they see what we do, the types of patients we treat. But I think you're definitely right. I mean, it's grassroots, and it's amazing we don't have more applicants. It's, and most of our colleagues who graduate and get there will do really well, because there's a need out there. There's a need out there. Yeah.
Joe?
No, you just triggered something, and all of the recruitment efforts, and trying to figure out what works well, what doesn't, maybe what hasn't been as successful, we'll say. And that's a really valuable point that you just touched on, that maybe as a profession as a whole, figuring out some way to find these opportunities. Oh, there's a high school event on this day or this day, and then finding groups of people that are willing and interested to participate. Then, okay, we need someone to fill this Saturday morning or this Wednesday afternoon, and sharing that responsibility through the whole community rather than putting it on the schools, which obviously have a vested interest, but
Right.
the community as a whole has a vested interest here. So I think that was a
And I think our local societies can really take a run at that. So that's one thing I'm trying to work on with the CPMA, is get our local presidents and say, hey, just start at the grassroots level. Yeah. I think get it going. The other thing I was going to mention is my involvement in youth sports, coaching, and being on the boards and stuff. If you're active, it's amazing how many community people I reached that didn't know what we did. Mm-hmm. And then being visible, coaching, and being able to talk and see. I was also very involved in the community chamber of commerce and service clubs. And a lot of them, once you get involved, you have to get involved and get on boards and start talking to people. And then it really increases awareness at multiple levels. And I think, I'm sure it's a challenge for a lot of other professions too, but definitely I think for us, it's always been an issue. We all need to get out there and get on panels and volunteer time. Doesn't take a lot of time if more of us are doing it.
Well, Tim, we're running a little low on time. Joe and I want to thank you for carving out time in your busy week to join us on Dean's Chat.
You bet. Pleasure.
And we're going to send you one of these Dean's Chat cups, and your beverage of choice can be drank out of it, of course. And to all of our listeners out there, if you're listening on Apple Podcasts or Spotify, please give us a 5-star rating. And if you're watching on YouTube, by all means, become a subscriber. So until next week, Tim, thanks for joining us. Joe, great seeing you again.
Thank you so much, Tim. As always, it's just been a pleasure.
I appreciate it. And a lot of good points. I think the podcasts are a great idea because we're reaching a lot of different topics. So great job, you guys. Appreciate it.
All right. Cheers, everybody.